Good evening. My name is Catherine Harley, and as the CEO of NSWOCC, I'd like to welcome you to the NSWOCC and the Wound Ostomy and Incontinence Institute Continuing Education webinar. You see the risk for pressure injury, now let's reduce it. We would like to thank Stryker and their SAGE division for their partnership in making this education possible. We have a very special guest expert who will be presenting live this evening from the United States. There will be time for a live question and answer session at the end of the presentation. So please put your questions in the Q&A box, which is located at the bottom of your Zoom screen, and we will field as many questions as we can. I would now like to ask Brittany Taylor, who's the product manager of SAGE, to introduce Dr. Joyce Black.
Thank you, Kathy. Good evening, everyone. As Kathy mentioned, my name is Brittany Taylor. I'm the product manager with our SAGE business unit at Stryker. Just on behalf of Stryker, I wanted to say that we're delighted to be able to partner with NSWOCC for this session. And I have the distinct pleasure of introducing our presenter this evening, Dr. Joyce Black, who will be sharing her expertise on pressure injury prevention. Joyce Black is a professor in the College of Nursing at the University of Nebraska Medical Center in Omaha, Nebraska. She teaches senior level nursing students in critical care nursing, advanced pathophysiology to nurse practitioner and physical therapy students, and supervises research activities of graduate students. Her current funded research is in the area of pressure injury prevention. Dr. Black has years of clinical experience as a medical surgical nurse at St. Mary's Hospital in Rochester, Minnesota, affiliated with the Mayo Clinic. Her clinical practice has been in orthopedics, critical care, burn care, respiratory diseases, wound care, and plastic surgery. She is certified by the Wound Ostomy and Incontinence Nurses and is a fellow with the American Professional Wound Care Association and the American Academy of Nursing. Dr. Black served as lead editor of Medical Surgical Nursing, a textbook for undergraduate nursing students. She is the past president of the National Pressure Injury Advisory Panel. She has also served as the co-chair of the task force to define deep tissue injury and the co-chair of the task force to update the definitions of the stages of pressure injury. So we are in very good hands this evening. Now, without further ado, I will turn it over to you, Dr. Black.
Well, thank you very much, Brittany. I have to shorten that introduction. It's a little bit too long. And thank you, Kathy, for inviting me to present to my colleagues to the north. I've never thought that Canada was actually a foreign country. I used to go there as a child all the time. So we're going to tackle this issue of pressure injury prevention. You're using a risk assessment tool, I'm sure. Or if not, you're looking at the patient and going, I don't need a risk assessment tool. I can tell that patient's at risk of pressure injury. What are we going to do about the problem? Let's see if I can advance these slides. There we go. I'm sure you could assume that I am part of the Stryker SAGE business as a consultant and on the speakers bureau for them. So in 2016, NPIAP redefined pressure injury, and I'm sure you've seen the updated definition. The changes that I think are the most significant to you are highlighted in red on the slide for you. We changed the word bony prominence as the only place a pressure injury could ever form with the word usually. Usually pressure injuries form on bony prominences because they're not well padded, but that's not the only place they form. And we sometimes get stuck in what is this wound? Is it a pressure injury or is it something else? Because once it leaves the bony prominence, then we don't know what to do with it. So don't get stuck in that paradigm. And of course, we are learning a lot about the number of devices that can lead to pressure injuries. Really, any tissue exposed to pressure, be it under the body or on top of the body, such as a medical device, can lead to a pressure injury. One of the other things that really needed to be highlighted is this simple clinical example. You have two patients that you're caring for. They are exactly the same. They're the same age, the same diseases. Everything is the same. One patient gets a pressure injury and one doesn't. So we've got to think about what's the difference in the person. What's the tolerance of their tissue for pressure? What's the tolerance for shear? What's the tolerance for microclimate? And we don't do that well. We tend to kind of get stuck in some of the basic practices. So I'm going to stretch you a little bit tonight and see if I can move you a little bit forward into some new thinking. Here's the 6 stages of pressure injuries on the sacrum. I know you've seen every one of these stages, and obviously they are not linear in that we don't go from 1 to 2 to 3 to 4. In fact, many times, as you well know, we start with deep tissue pressure injury that becomes an unstageable wound and then a 3 or 4. So even though I put them on the page, moving from left to right and top to bottom, that's not the way they appear clinically. Well, here in the US, pressure injuries cost a small fortune. We know that almost 2.5 million people get pressure injuries every year. Those are new cases of pressure injuries. We know that somewhere around 60,000 people die of them, and they die of sepsis from the wound. We had no idea until very recently when Bill Padula started to look at the cost of pressure injuries at $27 billion. That's a lot of money, whether it's Canadian dollars or American dollars. That's a lot of money. Bill did this work by looking at the prices attached to the reported cases of pressure injuries. All right, yep, you see it, don't you? What about all those wounds that weren't reported? Yep, that's exactly right. So this number is probably higher than that. And in our country, if a patient develops a pressure injury in the hospital and it becomes full thickness, the hospital's not refunded that money. They're not paid for it. So this also doesn't include the non-reimbursed dollars for pressure injuries. It's enormous dollars. Whether you count all the things it includes or not, we're still at $27 billion. Huge number in anybody's budget. We have a division of the government here in the US called the AHRQ, and they are the arm of our federal government that looks at what we consider to be avoidable hospital-acquired conditions. So back in 2007, the federal government here said, you're not going to get paid for surgical site infection. You're not going to get paid for catheter-associated UTI. You're not going to get paid for pressure ulcers when this was written. And so they give us these numbers every so many years and basically tell us, again, looking at reported cases, how well we're doing. And you can see over on the right-hand side of the slide, we don't look too bad. We're down 13%. And they tell us that that saved $7.5 billion of healthcare money. But we have a problem. I have a problem with the circle, don't I? Pressure injuries are going up. We're not getting those numbers down where we need them to be. You can see surgical site infection also went up in that 3-year period of time. So we have work to do. You have work to do, and hopefully we can get to that. Well, what I want to talk about for the rest of our time tonight is what I'm going to call the 4 elements to guide the interventions based on the level of risk that you've identified. We're going to look at the intensity of pressure, the duration of pressure, how we can manage shear, and then how we can improve the health of the skin and soft tissue to improve the tolerance of the soft tissue for pressure. I love to add art to my slides, and so I found this picture of a medicine wheel from the Native American population here in the US. And so you're going to see this thing appear. I'm going to spin it as we go through these 4 elements tonight. We're going to start at the top with the buffalo, and we're going to look at the intensity of pressure. So I think it's a cornerstone, isn't it? That the reason we call pressure injuries is that they form from pressure. So our cornerstone intervention is to reduce the intensity of pressure. The model that I have in front of you on the right-hand side of your screen is one that was put together by Dr. Koziak in Minneapolis back in the 50s. And we don't use this exact model anymore, but I think his points are so valid that they're worth talking about. So on the x-axis or the horizontal axis is the time of 0 to 12 hours. And on the y-axis is the intensity of the pressure against the skin. Now, what he was able to do in a lab setting was apply pressure at 600 millimeters of mercury. That's twice the elevation in a blood pressure cuff. And so you know that you wouldn't tolerate that. If somebody pumped the blood pressure cuff up to 300 and then let it down 2 millimeters of mercury at a time, your arm would be so ischemic that you'd be telling them to stop what they're doing. So we really don't have a lot of clinical conditions that have people exposed to that level of pressure, except when they're laying on the street, on concrete, on the basement floor, on the kitchen floor, where there's uncontrolled, very intense pressure. And what you can see from Dr. Koziak's model is that the shorter time frame goes with the more intense pressure. So what he's saying is you can get a pressure injury in 2 hours if the pressure is extremely high. So what we're going to look at in this element is what do we do to reduce the intensity of pressure? We're going to look at support surfaces. We're going to look at how we offload the heel, and we're going to look at what we do with medical devices. So moving to the support surfaces, I'm pretty confident that none of your hospital beds look like this. In fact, that's not my bed either, but I have all these throw pillows on my bed, and I have, it's very decorative. And each morning I get up, make my bed, put all the fancy pillows on it, and it sits there like it's there now. Nobody's been back in that bedroom. So my husband will say to me, I don't know why you do that. Why do you do that? I said, because I like the way the bed looks. He said, but nobody sees it. You make the bed and you leave the bedroom and you come back, some 15 hours later and take it all apart and go to bed. Well, I had to come up with an excuse. So I said to him, well, in case the firemen come or the police come, I want them to know I'm a very tidy housekeeper. So we don't have hospital beds that look like this. Might be nice if we did. When I look at the guideline that came out in 2019, there really isn't a lot of data that will guide us on what kind of support surface we should be using for patients. So here's the general recommendations that I think we all live with. In the ICU, you need a bed with high immersion. You need something the patient sinks into because they're not making any independent movements. So they can't really manage on simple foam. To lay on a foam mattress, you have to be able to move yourself a little bit. Probably a good idea in the ICU to have a low air loss component to it, perhaps an alternating pressure component to it, something to augment what you're not able to do clinically because of the condition of the patient. Out on the general units, those are patients that should be able to move themselves, perhaps using the side rail to turn themselves. So there, 4 inches of foam with alternating pressure would be great. I don't know how many people in Canada fit the bariatric definition. We have a lot here in the States. So we need to be cautious that we are putting them in beds that are wide enough for them to be physically turned. If the patient's in the bed, and our standard hospital bed's about 39 inches across, if the girth of the patient is 39 inches, there's no place for them to go. So you need a wider bed. There are also the bed companies produce beds that indicate, they can support 500 pounds of body weight. And that's a safety feature. The mattress is not going to collapse under that body weight. But I want you to think about, can that patient move in the bed, and make your decision about beds based on that. So I'm going to talk now for a little bit about that patient who's supine. So who's this patient? This is the patient on the OR table. This is a patient in critical care who's in a massive fluid resuscitation state, massive hemorrhage, massive burns, or perhaps in Trendelenburg. So that person is completely flat. I'm going to focus on surgery for just a couple minutes. We know that the longer the patient's in surgery, the greater the risk of pressure injury development. And we see The majority of them being on the buttocks, on the sacrum, a high number of them on the heels in patients having predominantly either thoracic or abdominal surgery. Some of the orthopedic cases are also that way. Some of the head and neck cases done in the operating room are done flat, and others are done with a markedly elevated head. And then we have to factor in the shear force. So we'll get back to that one. Probably the highest risk patient that we have is the open heart case. And we know that they have an altered blood supply. It's non-pulsatile, and that changes the ability of the body to perfuse the skin. So that's the group that we actually started looking at first when we started looking at the OR. So when you're trying to figure out in the operating room, who's at risk of pressure injury, these are really the driving factors. How sick are they? So rather than look at, are they diabetic? Do they have pulmonary disease, etc.? We're just going to ask you to use the anesthesiologist risk score. It's called the ASA score. And when that score is 3 or 4, that patient's at high risk. Just so you can have a point of reference, a person having elective surgery that has absolutely nothing wrong with them would be a 1. A patient with stable disease having surgery would be a 2. And then the more ill they are and the more urgent the operation, the higher that ASA score goes. We know the length of the case, once it reaches 3 hours, the risk goes up dramatically. And of course, what your OR staff are going to ask you is, well, how will I know the length of the case until it's over? So what you need to do is look to see, when is the next case scheduled? So if this is first case, patient's going on at 7 in the morning, and the same surgeon doesn't list the second case until 11, he expects that case to run close to 4 hours of time. So that's what we use to judge pre-operatively what the expected length of surgery is. How intense is the pressure? You can see the patient's face up on the upper right. He had an elective lumbar fusion done and ended up with these pressure injuries on his face. He was prone for the operation. Now, that's a pretty unexplainable event to this man, because I can tell you right now, it was not on the consent form that he may develop pressure injuries of the face. We had a couple issues with that, and we had to really track back and look at how well were we padding these patients that were prone. The other patient picture is an open heart case, a very classic pressure injury on the sides of the buttocks for being flat. We know that blood loss during the case is also a predictor. That's, again, something you have a hard time telling preoperatively unless the surgeon has typed and crossed a great number of units of blood. If the patient becomes hypothermic or hypotensive during surgery, there's a greater risk of pressure injuries for that patient. So I wanted to look at the interface pressure on an OR table. Now, I know that many of you realize that interface pressure is not the only story, but it tells a pretty good story, because at least I have a picture. So you're looking at a patient on the OR table. And if you're familiar with pressure mapping, you know that as you get to yellow, orange, and red colors, those are higher pressure areas. And when you look at this, you can see that in this patient, the highest pressure is not on the sacrum. The highest pressure is actually on the butt cheeks. You can also see elevated pressures on the heels. When you look at the pressure injury that develops in a patient who's been supine on the OR table, looks just like this. That pressure map was not done in this patient. I want you to know that. But that's exactly the pressure injury location in the operating room. And so it's pretty easy for us to associate that look of that wound to the events in surgery. Now, why is that important? Well, if you're going to reduce the risk of pressure injuries, you've got to know where they start. So even though our surgical ICU, our cardiovascular surgical ICU, used to get, accused of all sorts of things in these patients, because all the pressure injuries seemed to start in the cardiovascular ICU. Well, they appeared in the cardiovascular ICU, right? That's where they showed up. They actually started in surgery. So one of the things we did very early on was looked at, what are the surfaces on our OR tables? what are we using to dress high risk areas? Now, one of the things that happens in surgery is that people are turned during the operation in order for the surgeon to have better access to the tissue. So this is a patient who's now been turned onto one side. It took us a while to figure this out because we would see unilateral pressure injuries, and we knew the patient had been in surgery. So there's your example, a unilateral pressure injury. Well, how did that happen? So I actually went down to the OR one day and said, okay, tell me the story here. How are we getting this wound? Because I can tell you that the timing matches. This guy was in surgery 3 days ago. So I know it likely started in the operating room. And the OR staff said, we planed him during the case. Well, of course, I don't know what that word means. So I said, what do you mean he planed him? We tipped him, we tilted him so we could get at the back side of his chest during surgery. Oh, okay. Well, now that makes sense. I couldn't figure that out before, but if you see these unusual wounds, I still want you to think about surgery. So most OR acquired ulcers are deep tissue pressure injuries. This is a litany of them. I'll just walk through them real quickly for you. So starting on the right, that's an open heart case. You can see the pressure on the flat parts of the buttocks rather than the sacrum. The patient in the bottom is also an open heart case, but that patient's older, so she doesn't have the butt mass that the patient on the right did. She's an older woman. The patient on the right was about a 50-year-old guy, so he still had healthy buttocks that lifted his sacrum off of the bed. The patient on the left had a Whipple done, and you can see the necrotic area matches the location of a typical OR ulcer. And then he got septic after surgery, and he got put into critical care where the head of the bed was elevated. And that gave us the newer, younger DTI up along the upper edge. And the patient in the top was one of those patients that was planed, because I can tell you, I didn't photograph it and I should have. I can tell you that the other butt cheek doesn't have a wound. So that was a patient who was tipped during surgery. So how do we reduce the risk of pressure injury in the OR? Because I can't change the intensity of the pressure. Pardon me, I can't change the duration of the pressure. I can't tell the surgeon to stop the case. So if I can't change the duration of pressure in the OR, I have to reduce the intensity. Those are the only two variables I can manipulate. So I need to change the surface, put an overlay on the surface, or put preventive dressings on high risk areas for that patient. So those are our two most manipulatable variables, either intensity or duration. And we try to do both, but sometimes we're stuck, particularly here in OR. This is the best that we can do. So here's those prone cases. What you're looking at is a Jackson frame, which is a very typical bed that they do OR surgery in the prone position because they can walk right up to the body. So this is the type of bed that a patient would be on for a lumbar fusion. And you can see the injuries that come from these mattresses. They're not well padded. And I don't know, I hope you can see that the abdomen is actually kind of hanging free. Do you see that? Between the two padded blue covered pads. The abdomen is hanging free because if you put pressure on the abdomen during surgery, they have more bleeding when you put pressure on the liver. So they intentionally leave the abdomen kind of hanging there. Now we're certainly proning a lot of people with COVID, and we have this exact same profile of pressure injuries that form on the face, on the chest, on the shins, and so forth. And so we'll look at that in just a second. So the deep tissue injury problem in the prone patients is because that tissue is very poorly padded. You don't have a lot of fat on your cheekbones and your chin and your forehead, and the risk becomes very high very quickly. In fact, as I said a minute ago, we're proning a lot of people for ARDS, be it COVID or non-COVID. And if we don't adequately pad them before they go prone, we can really increase the risk of pressure injuries. Some work done just looking at plain ARDS patients a number of years ago found that the odds ratio is up at the 1.37. So their risk of pressure injury is much higher. And in fact, pressure injuries is one of the most common complications in the prone ARDS patients. So calling on all of you wound care folks to help the ICU out when they're proning patients, to make sure they're adequately padded and adequately moved once they're in that prone position. So we certainly have struggled with COVID. I know that you struggle in Canada. We have struggled in the US. I think we're not out of the woods yet by any means. I hope it happens soon, as I know you do. One of the things that we see in the patients with COVID is an unusual skin change. The virus itself attaches to the ACE receptors. Those are the receptors that cause blood vessels to constrict. That's why we give ACE inhibitor drugs for hypertension. And when they attach to those receptors, they accelerate clotting. So they cause the vessel to close. Now the blood doesn't move through and it clots, and the virus accelerates clotting. So we have higher incidence of PE and MI and stroke in those patients. The skin change that you see in COVID, though, is fairly unique. If you look at the bottom picture, that to orient you a little bit, the patient's head is off on your left, and you're looking at the fold of the buttocks, more so onto the flank and side of the buttocks. You see that purple tissue change. And of course, the staff are telling you that's a deep tissue pressure injury. It's purple. And in a couple of days, it'll blister off. And you look at that and go, it's not a pressure point, right? So unless the patient was laying on a reindeer toy with antlers and legs, that's not a pressure injury. That's a COVID skin lesion. Now, the other thing that we're seeing is that patients who are not intubated yet are sitting up very high in bed. And our beds, of course, don't go to full 90 degrees. So their pressure's actually back on the buttocks cheeks. So if you look at the patient on the top, that's a patient who we tried to manage without intubation and we couldn't do it. So she had to be intubated and proned. And about 24 hours after she was proned, those wounds showed up. Now the ICU staff said there was no pressure on that tissue. So how can that be on us? We had nothing to do with it. Well, that's ischemic skin that didn't tolerate pressure very well. And so one of the things that the NPIAP worked on a year ago already is the idea that not all pressure injuries in COVID patients are avoidable. And it's because of this ischemic skin. Well, you may be seeing this too in your COVID patients, that early process of attaching to the small vessels leads to something called COVID toes. These were patients who were not hospitalized, called the clinic and said, I have these purple spots on my toes and they hurt. And so they sent some photographs. And of course, we were doing everything by remote telehealth. And then 7 days later, this was the appearance. So you look top to bottom on these photos. They went on to ulcerate, very much like an arterial ulcer, extremely painful in a pretty healthy person, apart from some early symptoms of COVID. So when you have this patient now who is completely flat in bed, and in this case prone, what do we do with them? You need to make sure that their head is properly cared for. And we've been using positioning pillows that we can put indents in the pillow and make a little cup to hold the ear and make a little trough to hold the tubing, just to get the pressure off. Then we turn the head side to side every 2 hours, and we move the arms into what's called a swimmer's position. So the face is facing the flexed arm, and the other side, the arm is back. The problem is moving those arms and head. You really need help from your respiratory therapist. And you need to be careful that you're not pulling that shoulder aggressively, because you can injure the rotator cuff or the brachial plexus. One of the other things that we see is injury from the endotracheal tube, particularly if you're using a hard device to hold the ET tube in place. So we strongly recommend that you actually tape the ET tube in place. So a question, of course, that comes up is, how do you know the difference between a COVID skin problem and a pressure injury? And so again, you're thinking about where's the wound and what position was the patient in, recognizing that there's going to be a delay in that deep tissue injury presentation. So here's another pressure map. This time the patient is sitting up pretty high, sitting up at 60 degrees. And you can see the pressure extends across the buttocks because they're sitting on their buttocks, but the pressure is pretty high in that area. This is the patient's image. This is a patient who was sitting at 60 degrees head of bed elevation and went on to become completely necrotic. Those were necrotic deep tissue injuries that required flap surgery to actually fix. So this was a pressure injury in a patient at extremely high risk. And I want you to think again about the idea that not all of these are fully preventable. I'd refer you to NPIAP for some documents on that if you're interested, just trying to kind of get ahead of the claims that will come, because these people survive COVID and then end up with these massive pressure injuries. The COVID skin lesions do appear ischemic, like the reindeer one we just looked at, but the pressure injury, the pressure component needed for pressure injury is missing most of the time. Think about the toes, think about the reindeer wound. There was no pressure on those areas. The one I'm showing you here is an ischemic patient that ulcerated because of the position that he had to be in to breathe. So the COVID lesions go on to blister. You can see now we've lost some of the epidermis. And so here again, they get confused with deep tissue injury because deep tissue injury also blisters like this. So you've got to do a good history. This is another example of a patient with a skin lesion that's not on a pressure bearing area. You can see the gluteal cleft just off on the toward the bottom of the right-hand side of the picture. And yes, the area over the sacrum may be due to pressure, but the rest of that wound is all due to COVID and would not be counted as a true pressure injury. So moving into the Semi Fowler's patient, gosh, this is like everybody, right? Everybody in the hospital's in Semi Fowler's position. So the group is the ventilated group, the tube fed group. Our patients watch television. You got to have your head up to watch TV. And even people at home that are sitting in recliners are often semi-reclined. This is the most common location of the body that pressure ulcers form in. And so we really need to appreciate where the risk is coming from. So this time, the pressure is going to be on the sacrum in these patients. And it's difficult to reduce the risk all the time. We're going to talk about this in just a minute. So I pulled a little data for you. The odds of developing a sacral pressure injury when people are turned every 3 hours. I know we try for every 2, but I actually think every 3 is pretty good. If we do it well, do it adequately, use wedges to hold them there, we can reduce the incidence of pressure injuries down pretty far. You're down to 0.5 and 0.2 increased odds. That's next to nothing as far as compared to inadequately turned patients on mattresses that are too stiff. So here's some more pressure mapping for you. This is the pressure in a Semi Fowler's patient. And you can see a very different pattern, right? Than the flat patient. The pressure's on the sacrum because when the patient is in Semi Fowler's position, the buttocks spread apart and the pressure gets laid onto the sacrum. When you look at an image of a patient with a sacral pressure injury, it matches perfectly where the pressure came from being in that position. So who are the other sitting patients? So one of the things that we have in the US is progressive mobility. And I know you have it in Canada because I spoke to some wonderful nurses in Nova Scotia a couple of years ago, and they had a very aggressive progressive mobility program. In fact, if you're on the line tonight, I quote you guys all the time. So these now are patients that are sitting up in bed or sitting up in a chair. They're sitting erect. So I've got the bed in a true chair position. What we're seeing, though, is we get orders from the doctors to get these patients up as tolerated. And as you can see in this image, this is one of our patients. He is perched on the chair edge. He's going to fall. We were actually asked to see him for his venous leg ulcers. The chairs that we have in our hospital are not very well padded, and we put our patients in those chairs and have them sit for hours on end, and they can't reposition themselves. So we've really created a unique risk factor here in that we want you out of bed as part of your progressive mobility program, but you're sitting too long. So when you're sitting on the ischial tuberosities, you get a lot of stress from the direct pressure on the ITs. And there's not a lot of skin between the IT, which is a very sharp bone, the ischial tuberosity, and the buttocks. When the stress is not relieved, there's actually strain in the tissue. So this is some MRI data that was computerized to just look at how intense the pressure is at the right ischial tuberosity. And again, using that same color coding system, this time the pink represents the highest risk, at least on these images. And it gets high in patients who are sitting erect. So what can we do to reduce that risk? Well, one of the things that must happen is the patient must be repositioned in the chair. It has to occur hourly. Some of them can do it themselves, many cannot. And one of the things that we've been doing is something called march in place. And we have the patient stand up at the edge of the chair and move their feet around and then sit back down. We do that hourly. We are struggling to maintain compliance with it, but it's an excellent program. So we hope to maintain it. You need to have a chair cushion or a mechanism to reposition the patient, because as they slide down, they will eventually become a Semi Fowler's patient and put all the pressure back on their sacrum. You can use tilt and space wheelchairs, which are ones that tip the patient back. But I do think one of the important pieces of this story is once the patient's back to bed, put them on their side, get them off of their back. They've just been on their back. So get them onto their side and you should see, hopefully, reperfusion of that tissue. So moving to the heels, here's our 6 stages of heel ulcers again. Pressure injury on the heel occurs very, very quickly for a number of reasons. The calcaneus is very poorly padded. A lot of people have arterial sclerosis and they have poor ability to reperfuse that tissue. They're on vasoactive meds, so the ones in critical care, such as Levophed or norepinephrine. They have immobile legs, or they have neuropathic disease and don't realize they need to move their legs. So some approaches for the heel is to get the heel off of the bed. Doesn't need to be off the bed very far. It just needs to be off the bed. If they can't get the leg up, if there's a medical reason why you can't float the heel, then at least put some kind of dressing on the heel. If you have a very high risk patient, so exactly that list I've given you there, they need to go into boots because they really need to be, you need to be confident that the heel is off of the bed. If they're highly ischemic, you may want to try fleece boots to see if you can improve perfusion. A misnomer in our world is that we think that support surfaces are going to fix the heels. There's the heels. You can see they're bright red no matter what position this patient was in on the support surface. Their heels are still in contact with the surface. So if you're not floating the heel, you're not protecting the heel. The other thing, and I'm sure you guys use Braden scale. Barbara is retired here in Omaha. And so we, of course, use it, and we have for a long time. But the Braden scale does not predict heel ulcers. There's nothing in there that makes you look specifically at the heel unless you read very carefully the immobility section. So what I want you to ask is, does the patient move their legs? And if the answer is, well, they could, but they don't, that still means they don't. So if they're not moving their legs, the heel is on the bed. You may want to add to your assessment capillary refill and pulses, normal sensation, and then any use of anti-embolic stockings increase the risk. And so you may be missing the person who's at risk. The Braden's not going to identify it for you. So a number of years ago, we created what we called universal heel precautions, and I still think they're good. You should be inspecting the feet and heels every shift. That means taking any stockings off, taking any sequentials off, getting a good look at the heels, braces, splints, all of that comes off. Checking for pulses, checking the condition of the skin from those medical devices, and then making sure the skin of the feet stay moist, not wet, to try to help just the health of the skin. So I get asked all the time, well, can't we just use pillows? You know, don't pillows work? Why should we buy heel boots? All right, hang on. Take a look at this picture. Now, let me tell you that this patient had a total knee replacement of the right leg yesterday. The right leg, yeah, you're right. The one that's not elevated off the bed, that doesn't have a stocking on it, that all of the precautions that we do for clotting and pressure injuries were applied to the wrong leg. So there's a great example of a pillow being used that's purposeless. So if you're going to use pillows, just be sure that the leg doesn't compress the pillow so that the heel's on the bed. Make sure the patient doesn't kick the pillow off, because then the heel's on the bed. And some of my patients pull the pillow up under the knee, so it's not doing them any good either. So be cautious before you put all your eggs in the let's put their heels up on pillows basket. You may not find that it's adequate. So let's move to duration. In a patient that is being automatically rotated in the bed, their body never leaves the bed, and so the pressures never completely go away. You can't rely on the surface to move the bed. So how do we move people? We've kind of talked about some of this, so I think I can go over to the part of the slide that's on the right. Be sure that you're looking at just moving them in bed, first of all, just getting them to move, and start gradually turning them. There are a lot of nurses who are fearful to turn patients. And I think if you use turning and assisting devices, you can gradually move the patient and see their response. I'll caution you not to move them onto their left side first. Try moving them onto their right side. We have a little more cardiovascular irregularity when we turn them to the left. But give them a chance to recover. Don't immediately put them back on their back just because you see their heart rate jumps a little bit or their pressures fall a little bit. Give them a chance to re-equilibrate. Think about getting them in preventive dressings if they're not going to be able to be turned. And then if you're getting do not turn orders from your surgeons or physicians, I want you to renew that. Think about that as a restraint, where every 24 hours you're reconfirming with the doctor, you still don't want us to turn this patient, just to make sure that we're on the same page there. One of the things that Kathleen Bowman really spent a lot of her professional energy on is trying to help us understand when we move people, we cause cardiovascular compromise. It's the same thing that when you jump up quickly, your blood pressure is going to fall. But the answer is not to leave the patient lay in one position. That's the wrong thing, because all that will do is continue to weaken the cardiovascular system and the reflexes. So try moving them. That's what the turning sheets are great for, is you can get a little turn. You don't have to do a big turn to 30 or 45 degrees. So our goal, of course, is to get this patient into a 30-degree lateral position. And I want to draw your attention to this very old picture from NPIAP from I don't know how long ago. You can see her hairdo is like from the 80s, so it's probably that old. When you look at that body, gravity is going to pull that patient back into a supine position. I want you to start pulling that upper leg more forward, so you're moving the center of gravity up and over toward the face, not letting the body tip back onto the back. Definitely need, you can see the early wedge there. Definitely need to hold the patient up with wedges, because they're not going to have the ability to hold themselves in that position, particularly the unconscious or the extremely weak. When we try to turn the obese patient, it really gets to be difficult. And I'm going to direct you, if you haven't seen the study by Jan Powers, where she looked at if you used a positioning system, you were able to maintain the posture of the patient in bed, obese or not obese, more reliably, and therefore reduce the risk of pressure injuries, because you're getting them off of the sacrum. So moving into shear. Shear is a difficult concept to understand. It's the motion of the body sliding down in bed, and we can't control it. We live in a gravity-based earth, and so we need to be thinking about how can we help manage that. I found some nice data about the use of alternating pressure mattresses to help reduce some of the shear and some of the pressure, greatly reducing pressure injuries. So a good piece for you to think about when you think about your mattresses. So how do you prevent shear? Well, you need to think about the fact that it's going to be there, particularly if the head of the bed is elevated. So use some kind of absorptive product to get rid of the moisture so the skin stays healthier. Try to keep the head of the bed low as you can. And then try to use a layered preventive dressing to help absorb some of that shear force. Some of this is hard to prevent in entirety, so the best thing is just to appreciate that it's there and try to add another interface to the patient. The patients at 45 degrees head of bed elevation are the absolute highest risk for shear. And for those patients, I think you should turn any dressings that you have that are heart-shaped upside down, so that the fat part of the dressing is on the lower part of the buttocks. Not all the support surfaces are good at reducing shear. So ask your company that provides beds how good they are at reducing shear, and they'll be able to give you some of that data. But if you're seeing a lot of patients that must be positioned at 45 degrees, you've really got an issue with shear that you've got to address. You can't turn people well at 45 degrees. It's very difficult to get them positioned. When you are able to turn them, just make sure that you're getting that buttocks off of the bed. Well, the last section I want to talk to you about for just a couple minutes is how do we improve the tolerance of the skin? We need to look at nutrition. This is a wonderful document that looked at how much we stress people and how catabolic they are. And what they measured was urinary excretion of nitrogen. And you can see that in our major trauma patients and our major burn patients, they go to 40 and 40 grams of nitrogen expressed or released a day via the urine. And they stay catabolic for almost 3 weeks. So if you're working with patients that are extremely ill, they are going to be catabolic very quickly. And you need to really be thinking about how to get them adequately nourished. Work with your nutritionist, but these are some things that you can do for people who eat orally. You can give oral meds one at a time and use the supplements that are piling up on the windowsill. Liberalize the diet. This is not the time to worry about cholesterol and low fat and low carbohydrate. Let them eat whatever they want to eat. Be sure you monitor the weight and report weight changes. And then I think, if I'm sitting in my room and I have an odorous wound and I'm trying to eat watching the nightly news, I'm probably not going to be eating much. So do think about the social aspects of eating. It's a very important piece of how we normally dine. Another factor that alters the tolerance of tissue for pressure is exposure to moisture. So the more we can control the moisture on the skin, the more we can manage the incontinence, the more we can keep the skin clean and dry by not letting people be incontinent and remain in incontinence, is going to be a huge help for the patient. We certainly see lots and lots of risk factors for incontinence associated dermatitis. And probably the best reference I can give you that will really help you understand this risk factor actually comes from Dimitri Beekman, and I'll show you that document in just a second. I love this picture, and if we were live tonight, I'd be asking you to identify all of these wounds on this patient's butt. Many of these have to do with moisture. Apart from the deep tissue injury, these are all moisture-associated skin problems. So how do you manage it? This is the document that Dimitri Beekman put forth, and I know that a number of your experts in Canada contributed to this document. Obviously, it's cleansing the skin. It's keeping the skin as clean as possible, and then moisturizing the skin, even if it's incontinent skin, using some kind of skin barrier to keep the next episode of incontinence from damaging the skin. You want something that stays on the skin. We, of course, have a tendency to pile linen up like no other on beds so that we don't have to change the whole bed. Here's some great data on how each layer of linen makes the story worse. We increase the pressures against the skin, and we decrease the absorbency of the skin and all of the incontinence. So we really have an issue with multiple layers, and I've given you the data on that. We don't need the princess and the pea story anymore. The last piece I want to talk to you about, and then I'm going to turn it over to you, Kathy, for Q&A. We have poor perfusion in many of our patients in the ICU. These are not pressure injuries, but this ischemic tissue will rapidly ulcerate because of its inadequate blood supply. Be very careful that you're protecting these patients from injury. Vascular boots, a very good set of heel offloading boots that pad that skin well, is absolutely crucial for what you're doing. You've got to be aware that progressive ischemia will lead to significant gangrene and patient death. This patient died before we had to amputate the limb, but that would have been the ultimate goal for her. We actually ended up using metronidazole in the wound just to control the odor of the gangrene. So be aware of the significance of perfusion. So the last step, how you did all these things, how do you make it work? How do you make it stick? You've really got to have some criteria for the use of these products. You've got to use skin champions. You've got to trial the products before you buy them. And I can tell you many, many years of working with Sage, now part of Stryker, they're great to work with. So don't hesitate to ask for their help. Obviously, what I did tonight, building resiliency in your work, isn't the end. I can educate you. You look where education is on this trajectory. I can educate you all the time, but you have to pick it up. You have to make it part of your protocol. You have to adopt it into your practices. And that's the way that you sustain the change and keep your gain. You know, 1 month you don't have pressure injuries, everybody's heave ho, here we go. And you take your eye off the ball and the next month they're back. So we've got to look at systems that really push us to make this automatic as part of our everyday practices to prevent pressure injuries. So we went around the wheel. We looked at the buffalo, then we looked at the eagle, then we did the wolf, and then we did the bear. So we've gone all the way around the wheel looking at intensity, duration, shear, and tissue tolerance. So Kathy, thank you for the opportunity, and I'm available for questions.
Okay, and thank you, Joyce. I have to say, every time I hear you speak, I learn not just one more new item, I learn many new items. So thank you so much. I love the way you framed up your presentation. And I think you really drove home some very key points. The cost, I would say, is fairly relative to what we're facing in Canada based on percentage of population. One of the things that came up before the presentation was even halfway through was, will this recording be available, and will there be slides or a handout? And so I can confidently tell everybody who is listening to the presentation, if you registered, you will be getting an email with the recording. And I think you said you were going to do a handout, correct, Joyce?
Yeah, absolutely. Easily done today.
Okay, excellent. So if you do have a question, now is the time and the opportunity to ask it. Please put it into the Q&A box and we will try to get all of them answered. The first question is around tape. Are there certain tapes that are less likely to cause stricture in pressure, but hold an endotracheal tube in position?
Yeah, that's a great question. A lot of hospitals have taken away the ET tube holder because it's leading to pressure injuries on the face and going to tape. And a couple pieces of advice: don't tear the tape in half at any point. Use exactly the 1-inch tape and all the way through. You can put a film dressing on the cheeks and tape to that to avoid direct injury to the cheeks. You can use twill tape. We use twill tape. We don't use truly adhesive tape. And it's tough. If those hospitals that are starting to think about taping ET tubes, for a long time, we haven't taped ET tubes. So my advice would be, if this is something kind of new to you guys, find the oldest anesthesiologist you have in your hospital and ask him or her to show you how to tape ET tubes, because they did it for years and they know how to do it safely. So that will help you. But paper tape won't work. Silk tape will work, but it's pretty hard on the skin when you pull it off. So either a film or a skin protectant on the skin first, so that you don't tear the skin off when you pull the tape.
Okay, no, that's very, very beneficial information. And we have another question that's come in here. When you say that we should put a prevention dressing in place, what do you mean? A hydrocolloid?
No, I wouldn't use a hydrocolloid because the patients are going to sweat too much for a hydrocolloid. I'd use an adhesive foam, one that you could cut to fit. Everybody's body's different. So some of these patients you're going to prone have got very prominent ribs, and others have a very prominent forehead. So you might have to cut the foam to fit the shape of the body. I would use the most absorbent foam you have on the chin, because once patients are prone, there's no way for them to swallow their saliva. And so they get absolutely wet from the chin down, and it actually macerates the face. So use the most absorbent foam dressing you can find on the chin. You're still going to have to change it fairly often. But yeah, hydrocolloid would be too adhesive and non-absorptive. So that wouldn't help you.
Okay. Do you remove endotracheal tubes routinely to avoid pressure injuries to the mucous membrane or lips?
Yes, we move the ET tube, sort of depending on the risk profile of the patient. If this is a patient who has an abnormal mouth, we may move the tube every 2 to 4 hours. When they are supine, we move them each time they move. So you're going to have to move all the ventilator tubing anyway. So it's just as easy to move the ET tube. Now that's with the ET tube holder, where you can just close it off and slide it back and forth. But you really can't do oral care if you leave the ET tube on one side of the mouth for, hours on end. So yeah, we move it fairly often. Both nurses move it and respiratory therapy moves it. There's no reason either group can't move it.
Okay, and I'm just going to go back to the previous question where you responded to what type of dressing do you use to relieve the pressure, and the same individual has come back to ask what you would recommend for the heel and the buttock as
On
far as
a
a dressing to
supine
relieve
patient,
pressure.
yeah, we use a multi-layer foam dressing that we don't dress the heel very often. We dress the heel in patients that cannot lift their legs. So people in orthopedic appliances that can't get their leg off the bed. Other than that, we use a lot of boots. We actually use a whole lot of boots. So we use fewer heel dressings than we use boots. And then on the sacrum, the sacral, the heart-shaped multi-layer dressings.
Okay, and I know that in the presentation you had said to turn the triangular dressings kind of upside down so that the widest part of the dressing is over the widest part of the buttock area, correct?
Yeah, Kathy, that's right. Because once the patient's body goes up, then the pressure point comes down. So if they're at 30 degrees head of bed elevation, then the heart shape is perfect. But when they're higher, then you have to flip it top to bottom, not inside out, but upside down.
Okay. There is another question here. Are there any later reliability studies that show the difference in assessment of WOCNs, of what WOCNs have done via wound photography versus live skin assessments on a consult for COVID patients? So,
Wow, what a high-end
yeah.
question. Holy cow.
Mhm.
You've got a brilliant person out there in Canada with you. That's a very good question. I know that initially when we were using telehealth, we really struggled to get the patient to a place that was lit well enough for us to see the wound. And of course, you don't get to smell it. You don't get to feel it. You don't get to take in the gestalt of what's going on. So we had to add that. So it's not just a still photo. It's a movie that's going on while we're there. So we say and to be honest, it's usually the patient's daughter that's doing this because the patient's too old to manipulate the cell phone. So we say, well, I got to turn that a little bit. I want to see the side of the leg. And if you push on it, what is it? Is it soft and spongy? Is it hurt? Is it hot? We had to get all of that from them. And I think right now we're fairly satisfied with the accuracy of our assessments using telehealth, but we had to augment all of that. So you can't tell much from a still picture. You're taking a three-dimensional image and putting it in, a three-dimensional body and putting it in a two-dimensional image. You're missing a lot.
Yeah. Thank you. And we all know that proning has been a critical issue for patients that have been in ICU during the COVID first 3 waves in some cases. I'd like to zero in on that just a little bit. If you could just talk a little bit about the type of padding and the location that you would recommend for patients in the prone position and how often they should be repositioned. And I mean, there's a lot of variables in that, but the type of padding and location.
Yeah, sure. We use a positioning pillow for their head, like I talked about, that you can make holes in the pillow that stay in place, and we get the ear down. We had a patient early that ended up turned and his ear was turned over, and so half of his ear was blue when we got him back. Then we use the foam dressings to pad the shoulders, the ribs, the knees, the shins, depending on the anatomy of the patient. I mean, it's really very, very different from person to person. We have a proning kit that goes in when we get the orders to prone, and it contains all the dressings and the checklist and all those things. And then the surface, we have ICU beds in our ICU, so we don't add to that surface. Now, there was a year ago, where we were almost having to prone people on regular beds out on our regular floors because our initial surge was huge. when our plan was, we never had to implement it, but our plan was to put an overlay on the bed because that was a foam mattress and that wasn't going to hold a prone patient, because these patients were prone for up to 24 hours. And that was way too long to lay on a standard bed. That would still be my recommendation today. If you're proning on a standard 4-inch foam mattress, you got to add some kind of overlay to it to get you additional immersion. Then moving the patient once they're prone is moving the arms and legs and just moving what you can, lifting up one side of the body, lifting up another side of the body, just to relieve some of the pressure for the patient. What you'll see, those of you that have proned the ARDS patients, is within a couple hours, you'll see a huge improvement in their SATs and FiO2s. I mean, it's amazing. It's almost like a miracle when you watch it. So, but they still stay prone for quite some time due to the inflammation.
And of course, with the airway being so compromised, there are a lot of challenges, and it definitely takes a team when the patient is going to be repositioned. One thing I kind of zeroed in on is around heels. And you mentioned the Braden scale does not predict heel ulcers. And you mentioned a universal heel assessment. Do you have a reference that you could provide to our participants, because heels are a big problem?
The references were on the bottom of the slide, Kathy. I can tell you, as far as the Braden not predicting, that was some data from Sandy Berquist at NDNQI. And what she said was that the average Braden score for a person who developed a heel ulcer was 17. And that was at a time when hospitals were intervening when Braden was 16. And so there was a huge number of people that were not caught, us included. And so we looked at, you know, what's the story? And the story is the patient moving their legs? So I did put a couple references on the slide. I don't know that I know anything else right off the top of my head.
Okay, so we'll check them out. And we have time for one more question. And the question is, we struggle with implementation of nursing staff to complete interventions to prevent pressure injuries. What are your words of wisdom to get staff buy-in?
I can tell you what we've done over time. We had the same issues a couple of years ago in critical care, where the critical care, and I don't know which staff she's talking about, but the critical care staff were telling us things like, we're critical care. We're more worried about heart and lung and brain than we are about skin. And so what we did a case series of a patient who developed a deep tissue injury in critical care, came to the outpatient wound center for a year, and then died of sepsis from the wound. And we put the story up like a storyboard in critical care. And there were a number of people who said, I had no idea. She never had bad skin while she was in ICU. We didn't know that happened. We didn't know she died from it. Nurses by and large are empathetic people. And so telling the stories is usually enough to move them. Now, obviously you can get to the auditing level, you know, where I'm auditing the work that you're doing and I'm recognizing that you're not turning this patient as often as you should, or you're not turning them adequately. That also will make people change, but you know, obviously it's not the place you want to start. We have used a root cause analysis process for a long time, and that drills us back to, like I was saying, the operating room, drills us back to where the patient was when we think the pressure injury started and who was taking care of them. And that has also raised some awareness. On the flip side, I have to tell you the flip side, we've had pizza parties for units that had sustained low pressure injury rates, and we've rewarded them for the good work that they've done. So, you know, sometimes it's both a carrot and a stick.
Right. So I just have to squeeze one more in, because there was one more question that popped up just as I was saying last question, but this will be it. What is your recommendation to use on ears when a patient is on oxygen?
Number one would be to change to silicone oxygen tubing. It will not create as much pressure. Now, there's a place where you may want to think about other types of dressings just to line the ear. There is a plastic device. Here it's called an ear pal. I don't know what you would call it, or if you'd have it there. It's a tube that the oxygen tubing sits in. Well, the blasted thing's on the floor in about 3 minutes. So it would not be my advice to use that, but rather look at either padding the ear with a foam dressing, perhaps even a film dressing if you don't have the thing too tight. And then the silicone oxygen tubing was a big game changer and not horribly expensive. I heard RT told me it was about 25 cents more for one nasal cannula system of silicone, which I didn't think was a major outlay. I spend many more times that for coffee every day.
Right. So, well, on behalf of NSWOCC, Dr. Black, I want to thank you for such an informative presentation. I'm really looking forward to seeing the recording and getting the handouts, which will come out by tomorrow. And we really appreciate your insight. Very, very informative. And I'm looking in the chat and people are very complimentary. So thank you very much. And also thank you again to Stryker and the SAGE division for their support in helping bring Dr. Black to us. So thank you very much. And we hope to have you back someday.
I would love it. Thank you, Kathy. This was great to catch up with you. And thanks to Stryker for making it all work.
Thank you.